Hey y'all, welcome and happy Baby Friday. This is Betty Hovey with another healthcare happening session. And I am pleased to have joining me again today, my friend and colleague, Miss Sonal Patel. Hey, Sonal.
Hey, Betty. How are you? Good morning. It's morning over here. I know it's already noon for you.
We're into the afternoon here, and I know
That's right.
West Coast, they're morning, like 9.
Yep.
I'm not very good at 9.
Yeah.
I don't do 9. Let me see, where am I? There we go. I'm sorry, I couldn't see my banners. All right, so as people come in, please give us a shout out. Let us know that you're here so that we can say hey to you. I see that we're getting a couple now. Oh, Ladriba's here. Hey, Ladriba. She is one of my.
Oh. Hey, Ladriba. Good morning to you.
Yes, that applause was for you. I don't know if you can hear that or not. I did not. And we have Terry Fletcher from in California. She's a morning one out there. It's about 9. So morning, Terry.
Morning, Terry.
And John Piaskowski. I hope I'm saying that right. So
nice. Hey, John.
We got and Lisa Chavez Miller, who is
awesome.
From one of the chapters I've spoken at before. So
yep.
Hey, Lisa. So we are going to be talking today about the CERT program. But before we do, just wanted to, one thing, I don't know, Sonal, if you know this or not, I was kind of scrolling through. Today is National Doctors Day.
Awesome. Our doctors, it's their day.
So make sure, for those of y'all that are in the clinics and stuff, to tell your doctors that you appreciate them and happy National Doctors Day. So I thought that was an interesting thing. I didn't realize that. It just happened to pop up on my thing. I was like, oh, so I'll probably make a little thing up for a post later too. But yes, so happy National Doctors Day. And just wanted to, Sonal, for everybody, again, who may not be aware of who Sonal is. I'm sure, there probably aren't many, but just if you want to give a little recap on what you're doing here lately, and so for people who do follow you, so they kind of see what's going on.
For sure. So yes, I have started my own little venture. It's called SP Collaborative LLC. So for those of you who want to get in touch with me, thank you for putting up the LinkedIn page that I created for it. So you can always check out that page for any new posts that I make. I'm trying to make them daily, and reach out to me for any types of services, help that you guys need out there for coding questions, collaborative ventures that we can embark upon, like my good friend Betty Hovey and I are on. So many different things are in our pipeline. So I know in the weeks to come, we will share our good news. But nonetheless, the website is still being built. So I cannot wait for everyone to take a look at that when it's eventually up for all of you to actually see. I've been working on it and it just is almost done. So I'm really excited for everything new that is going to be coming out for me in the weeks to come. So yeah, I'm super duper excited. So thanks, Betty.
Wonderful. And also I'll don't forget Sonal's podcast. She does the Paint the Medical Picture podcast. So you can find her on Spotify and Apple whatevers and all that good stuff where you get all your podcasting things.
Yep.
So make sure you're checking that out too. And just for people to know, coming up for future sessions here on the broadcast on Healthcare Happenings on April 13th. So we will have Sonal back. And I just wanted to announce that's going to be our E&M Q&A, how we did that first one. And we kind of ran short of time when we were discussing things. So for anybody that has questions, for that session that'll be coming up on April the 13th. Make sure that you either DM, message me or Sonal on LinkedIn, with whatever your question may be. We had questions from last time, and I think we didn't get through all of them. So we want to make sure we did it again. So just send us questions if you have them. And that one's going to be devoted to, just discussing the 2023 E&M stuff. And then on 4/27, on the 27th, I'm going to have Rosamine Boppet. We're going to talk about appeals, sources, things like that to be aware of when you're working appeals. And then Sonal is coming back with me on May 11th. And we're going to do part 2 of that 3-part series we started on audits. And that one, the second one, is going to be on actually doing the audit. So things that you will use when you're doing it, things to look for, and how to pull a statistically valid sample and things like that. I have trouble with that.
I hate that word too. I hate that word too.
If I go
it's not my favorite.
Like this. So I have to stop. Slow down on it.
I'm the same.
Ladies, great lady. Lady says she's going to send her questions. So definitely just send your questions in.
Yeah.
And we will get to what we can get through, in the hour and have a good discussion. So, but today, rounding back to what we wanted to go through is, I had a guest lined up for today, and unfortunately she had to cancel with me on short notice. So I was trying to think of what to do. And Sonal was so nice to agree to come on with me, because I was like, I can do these by myself, but I like having somebody else to discuss them with. It's always a lot more fun, I think, at least for me, so that I'm not just talking to dead air for an hour and I have somebody to look at. But she had to cancel, so Sonal agreed to come on. So we were trying to think of something to do, and the CERT thing just popped into my head that, I was trying to think of different things that are out there that either people are unaware of because maybe they've never gotten one before, or they have and they didn't know what to do, and they didn't really understand what was going on when it happened, that kind of thing. So I just kind of wanted to go through what the CERT program is, what they're looking for, and the 2022 report. I have the findings from the percentages for that. So we'll look at that in a little bit to kind of see where nationally, it is standing, and what you do if you get a request, like what you should do if you get one of these. And I think that's kind of the lineup that we discussed. Is it right, Sonal?
That's exactly right. That's exactly what we planned. Yep.
All right. Well, first of all, CERT, it stands for the Comprehensive Error Rate Testing Program. So, they just love their acronyms.
They do.
We do in the whole field, don't we? Everything
Yes.
has to be into COPD and CHF and, OIG. So, yes, it's
DOJ. I know.
Yes.
It's endless acronyms. CMS itself, right? I mean, yeah.
Well, it was funny because, talking, it took me a long time just on that because they used to be HCFA. And I remember HCFA. For those of y'all that haven't been in, long before it was CMS, it was HCFA, the Healthcare Financing Administration. And then they got a new administrator one year who didn't like the acronym HCFA. And so they changed it to CMS, the Centers for Medicare and Medicaid Services. And so then everybody had to, change all the stuff, and we couldn't say HCFA 1500 anymore. No. So if you hear anybody talk about a HCFA, that's what they mean, because that used to be what CMS was called. So just a little, just a little kind of tidbit in there for you. If you're ever playing like a trivia game,
Exactly. A fun fact. Yes. A blast from the past. Yep.
But yeah, the program, actually, the CERT program, they actually started measuring things back in 1996 for payment rates and improper things, and making sure that things were being paid for appropriately. So with CERT, they aren't necessarily, they're not looking at you for fraud, and it's not necessarily them, on first blush at least, looking at you. They're actually looking to see if the MACs are following what the requirements and the guidelines, and that's kind of how they put it out, that they're checking on the MACs.
Exactly.
The OIG was responsible, the DHHS OIG was responsible for doing these back then. And then in 2002, it turned over to CMS. So they kind of switched who was doing it. And then there was an act that came out that was called the Payment Integrity Information Act of 2019. And that was specifically to take a look at looking at high risk areas, and then to publicly you put out what those facts and figures are. And so that's when CMS, went to how they do things, and have been doing things, for a while now. So what they try to do is look at a statistically valid sample across the country. And so if you just think about that, how many providers, how many clinics, how many, it's like, okay, how do we get this to be to where it's not? Because if originally HHS, the OIG was only looking at like 6,000 claims. And so they said, well, you can't really extrapolate that out to the whole country if we're just talking about 6,000 things here. And then they couldn't do it how they do now. Like if you look at the report now, they break it down nationally, then they break it down by contractor, then they break it down by the contractor type, then they break it down by provider type, and they break it down by service type. So they have there's no way they could do that with only 6,000 claims. So they look at 50,000 claims is what they start with. So I think that, it is quite a nice number there where they're starting out. And then they go from there, and they have independent reviewers that are contracted with them to take a look at the records that they choose from the random sample of those 50,000 claims. So that's basically how it starts out. So Sonal, from that, is there anything in that area that you want to add to? I don't want to, be like jabbering on here for 20 minutes by myself.
No, that's a really well explained, succinct way of looking at what the CERT was established to do. So we don't want people to ever be confused that, again, the CERT is not looking at you or sending you a letter because they consider your patterns to be fraudulent, right? They are sending things out based on what they think your MAC in the region is actually doing, right? So it's more of an assessment of how perhaps the MAC can send out more education and guidance to the regions, right? So yeah, I was also happy to see that they increased the number of claims to look at from a very small 6,000, right, to a larger 50,000. So it's really, really good. When you have time, we'll go through it in the program later, but there is a 2022 report that I know she and I have read thoroughly, simply because we love to read 94 pages of PDF files daily. But it's laid out really, really nicely in terms of what the high volume things that they consider to be improperly paid upon. So it could be paid upon over the amount or under. And of course, I know in my experience, I have not been privy to many practices that receive things for an underpayment, right? It's always going to be an overpayment in my experience. But I know this particular report for 2022 does outline some of the criteria and practices that receive it for underpayments that were identified. But yeah, so the CERT program is one of the many in the OIG CMS toolbox that's there to protect the Medicare trust fund, right? That's the overarching kind of theme for these types of programs, is to protect what little is left in our trust fund.
Yeah.
So
yeah. And that was a good point you brought up with the over and under payment. Usually, when a payor themselves is sending you things, it's because they think they've overpaid you and they want the money back. Now, sometimes you may find where there were things, if you have someone audit before you send the records, you may find things that weren't billed maybe, or that maybe it was undercoded, the E&M or whatever. So you may end up getting an overpayment, something paid back to you. But to start off with, that's not what they're looking for. But with this, it's just a random sample of 50,000. So the likelihood, that they find over and under, is there, where they're not initially starting out with, hey, let's go take back money. So that's a very good point. And I just wanted, because I saw some of the comments from my HICFA comment earlier. Victoria Lowell is on. So hey, Victoria.
Hey, Victoria.
She was like, that's how you can age one of us by
you can.
HICFA.
Yep.
And then I'm really, really pleased that Dr. Kennedy is on. Welcome, Dr. Kennedy. Glad you could join us. That she's like, at least they didn't call it mama, or Medicare and Medicaid administration. And then John followed up just to end it, because I just think this is a funny little thing that works together. He says, can you imagine having to explain to your boss that you were on the phone with mama for 6 minutes? All right. So I love people that come in and hear her. So I love all these comments. It's really good.
That's great.
So yes, here is there is a CERT presentation that they made a PowerPoint for on the CMS website, and I will add this into the chat thing, because I know sometimes people say when that shows up on the screen they can't. They'd rather be able to click and, pull it out of the chat box. So I'll also put it in the chat box. So it's like a PowerPoint presentation that was put together where they go through the program and what they're looking for and what their improper payment categories are and stuff like that. This stuff we'll be talking about, but if you want to see it in a laid out manner, you can go and get it here from CMS. So I talked about that act, that kind of morphed into what they were using, but it's also part of the Medicare Program Integrity Manual. So once again, if you want to see how they've drilled it down and, compartmentalized everything, you can go here to the Medicare manual and take a look at all the things and see how they have it set out. So that's another resource that y'all have if you want to go and check things out. I like to try as much as I can when we talk about something to be able to have links and things to give people so that they can go and do some further research on their own and, kind of see how things may or may not be affecting them, or to what percentage, what amount in their practice. So these are the two things, if you're totally I have no clue what this stuff is, I would go to the PowerPoint presentation that CMS put up, take a look at that, because of course that's in more of a layman-y term, easy reading kind of thing, whereas the program manual, it reads like CMS's program manuals. So I mean, it's very detailed, but it's of course dry. So but these are two places where you can go and take a look at stuff. So once they get it out to the independent reviewers and they pick what their sample is going to be, then they start sending out the letters for records requests, or the ADRs. Some people may call them for additional documentation requests. And they want you to, give them the records for whatever dates of service they're looking for. And it will come with a letter that, lets you know that it's from the CERT program, that it's a CERT audit. And it will give you 45 days, to give the materials back to them. And I think out of anything, that's the biggest thing you want to pay attention to with anything that you get from a payor or CMS, especially, is their date, their turnaround time. Don't miss the turnaround time. If you need you're a small practice and they've asked for, 100 records, and you're like, I just can't get this all together in this amount of time, and I only have one part-time employee, that, ask for an extension, but don't ignore it and say, I just couldn't get it done. Make sure that you are meeting any and all deadlines that you are given from CMS especially, but also from any commercial payor that sends you records requests and things. Always make sure you've answered, even if you can't get it done, answer them and let them know that and work something out. Comment on that, Sonal? I see you shaking your head because that's like the biggie for me.
Absolutely. No, that's spot on. Spot on. You have to take action when you receive that envelope that comes to you. So make sure your staff is also well aware of how to route those types of correspondences that come from the government. Have a point person take lead and understand where that piece of document has to go to within your practice. Like Betty said, it is imperative that, once that piece of mail is opened, you document what the deadline is, right? What that is, make sure you calendar it, and make sure people on your team take action towards meeting the end date beforehand, right? Because the CERT letter is going to document to you how things are going to need to be sent to them. So you also have to be able to follow those directions to the letter. I'm pretty sure when you review these web pages that we provided to you in the comments, or we will be providing to you in the comments, you have to make sure that you don't send a photocopy of that first page with that barcode that the CERT applies to. I think it's page 1. So they want that original piece of paper sent back to them. So you have to make sure that someone on your team can read all of the documentation that's required from you, that's instructed to you on that CERT, very, very clearly on how to get that documentation over to the CERT contractor. Don't send it back to your MAC. You have to send it back to the CERT contractor. So again, it's a different name. So again, people on your team, someone has to understand, what that envelope is, and not just file it away somewhere on some shelf or in a drawer and never look at it. Like we're saying, it's imperative to take action immediately because it's coming from CMS. So we never want to let documents like that from them just fall off to the side, because it's a requirement that you at least respond to them by the date that they say you have to respond to them. And absolutely spot on. Best practice is, if you need more time, they understand that. So ask for a extension to whomever is on the bottom of that piece of paper, Mr. Smith, right? So contact Mr. Smith and get back to him and say, I need an extension, please, right? And so more than likely they can send you one for 7 to 10 days and so on and so forth if you need more time. But it's imperative that you contact the right person on that documentation, not just pick up the phone and call CMS and say, hey, I need this extension. They won't know what you're talking about. So you have to follow the instruction on that CERT letter.
Yeah, good. So yeah, when the reviewers get it then, so they do their audit, and once they do it, they start to calculate and put everything together and get all their facts and figures. And you can have partial or fully, wrong things if they find errors. So they do it, it's not like an all or nothing thing. You can have it where partial, like there were 6 things on the claim form, 4 of them were paid correctly, 2 of them should have been denied or whatever. They can have partial correct payment on them too. So they really kind of drill in when they're looking at things. And as we were saying before, I mean, then they really sort it out. So you can look at, like, if you go to the 2022 report, you can look for your MAC and say, okay, you know, where's my MAC, how they do, and sitting in with these things, you know, if they don't have a real high improper payment rate or with specific things or something like that, you know, you can see if they're good or one of the ones that are worse, that kind of thing, and take a look at it by that way. You can look at it by the type of provider, you know, all of those different things. So you can really pick apart the CERT report and use it, you know, to help you in your practice, you know, with your audit plans and all your things moving forward in the future, to kind of combat, you know, or get ready in case you kind of get hit with one. So I have put in the chat already. I put in the link for the manual. I put the link into that PDF, and I just put the link in for the 2022 CERT report. So all of that stuff is in the chat things now for you to kind of go back and pull out. But when they do the review, they will look at making their errors, and they have 5 different kinds of errors that they can come about. And that's when you look at the report, they'll have the percentages, and they have them for each one of the 5. So they're insufficient documentation, medical necessity, incorrect coding, no documentation, and other. So those are the 5 different categories that they put the errors in. And when you look at, you know, insufficient documentation, just what it sounds like, you know, they take a look at it, and what you have in your documentation is insufficient to support the service that you know, billed for on the claim. So if there's even a specific, so they look for if there's a specific documentation element that's missing or something like that. So it's just not meeting the criteria. For E&M, as an example, as everybody does those, you know, what you leveled out was you reported a level 4, but the problem addressed, the data, the what, you know, there were 2 of them that met the moderate level to support that. So you did an E&M, but you didn't do it documentation wise to the level that you reported. That would be insufficient documentation. As an example. Now, medical necessity. Sonal, you know, do you want to take medical necessity as one example, or what they'd be looking for there?
Right. So for the medical necessity, right, for pieces that are missing in documentation, they're going to want to see all of it based on your max region, right? So perhaps your documentation didn't support a particular LCD in the region, right? So these types of errors are, you know, comprising the majority. If you take the time to look through that 2022 report and you isolate the, you know, top 5, top 20 CPT or HCPCS codes that are affected, right, and they give you a breakdown, the medical necessity things are a must. And in general, what I find is that the types of services do have some sort of an overarching LCD or an NCD, you know, and when you whittle down and really look closely at providers' documentation, I know I've seen many a time where, you know, the nuts and bolts of that necessary covered indication, right? Those types of criteria are not really flushed out in the documentation. And so, you know, even though you're sending in documentation, it wasn't reviewed beforehand, right? You just sort of send it out the door and take a chance, right? But like we say on this platform, my platform, we always believe that you really need to have people on your team take a look at that documentation beforehand, right? Carve out time each and every month if you have a new service line or an old one, you know, and follow those particular policies, criteria, covered indications, what types of diagnoses, right? All of those types of things you should really pay attention to before you send these types of claims out to Medicare. because you can really get a good handle on your documentation beforehand when you do that. So then moving forward, you can find success when you receive these types of CERT letters, or if you need to appeal something, you can find success there because you know you've done the work, you've reviewed your documentation, and it's meeting all of their covered indications and everything for the medical necessity of the service, because that's the overarching criterion for Medicare and Medicaid, commercial policies too. The services have to be medically necessary, and that has to be found in your documentation. So, yeah.
Yeah, it makes me think of, now I haven't done podiatry for like forever, but with podiatry is a big one that, you have to indicate, how many category A's and category B's, they have all these different things that play in there that have to be in the documentation to support that code that you're reporting out on the claim form. So what I found sometimes, not just in podiatry, but in other places where there's similar kinds of things where they expect to see certain things in the documentation. The ICD-10 code is there,
right?
The procedure or the service is there, but those other pieces of the stuff that the patient has failed this and they failed that, and they did a trial of this. And, that's the stuff that the physician or APP, knows the patient did. And that's why they're moving to the next step, but it doesn't get into the documentation. And then whoever may be looking at that at the office, if they don't know it, if they look at the note, they may say, well, the ICD-10 is there, the CPT is there, it's connected right on the claim form, so I think it's good, without understanding those underlying things that also need to be documented. So that's something else too. If when you get those, I say, since you have the 45 days, make sure you're taking a look at the medical necessity issue and take a look at, are there LCDs or NCDs, and then rescan that documentation to make sure that that stuff is in there. Because that it might not just be that your CPT and ICD-10 don't match. It might be that inner workings of the requirements in there that just aren't there in the documentation.
Exactly right. That's a great tip. Right? Review those LCD policies beforehand, because you have that snippet of time where you can do that, right? Really analyze those LCDs and NCDs for your vein ablations, right? For things like that, you have to read the criteria, not just the CPT codes and the diagnosis codes. There's a whole bunch of text in between that will happen, right? And you have to read that for the covered indications of your conservative therapy has, failed after a trial period of 6 weeks, right? There's so much detail in each and every service that is applicable to an LCD. So yeah, you can make little checklists for your team and make sure that you're cross-checking, right? And is that in your new checklist that you made for the practice, right? And so make sure that the documentation from the provider includes that as well. So when it's time to come in and send these things out back to the payer, you know where to locate it, right? Within your EMR, because I know that they're all vastly different, and where they're organized is also going to be key for someone on your team to then pull it, right? Because I know things are tucked away in this section of the EMR and that section. So someone who's in charge of pulling that documentation and then sending it to the CERT contractor is also key, because if someone doesn't know where that new checklist item has been filed away into, that's going to be dinged again for insufficient documentation, even though it's there, it's in the EMR, but it wasn't provided.
Yeah. I've seen that many times where a practice has said they've contacted because they got a request, and whoever put the records together didn't put all the records together that were necessary. And so what they sent out wasn't complete. and they failed the audit, and then they come back and, well, it was in, but you have to, CMS can't read your charts from, wherever they're doing this thing at. So, you have to make sure what you got to send them, and send them everything you have to send them, so yeah, that's very important too. Incorrect coding, is the third one, and it's what it sounds like. It just was not right. That they look at the documentation, and what you reported isn't the correct code, for a procedure. Maybe you reported a complex procedure, and when the documentation is looked at, it doesn't support that. It should have been a simple procedure by what the documentation shows. It's just incorrect billing. Or also they'll say that the service was performed by someone other than the billing provider. So I see that a lot with not so much in CMS, but on the commercial side, I see that when practices are trying to bill incident to for their APPs, and the payer doesn't accept incident to.
Right.
In fact, I have a client right now that they contacted me because they said, we got this letter from the payor. They did a random, we got chosen for random, that every year they pull so many records from so many practices. It's just a random thing. It's not like they're not doing it from you being an outlier or whatever. They just said, okay, it's your turn. So they asked us for records. We sent the records in, and then we got a letter back that said, that all of these that the APP had done, that they billed incident to, they said that they were all denied. They were all incorrect. And they said because the name on the claim form didn't match the name on the record for that day of who did the service. And so they answered back, well, that's because it was incident to, and you'll see that the doctor signed off underneath it. And of course, that's when they found out, the payer came back and said, yeah, well, we don't accept incident to. And that opened a whole nother can of worms that we had to kind of go down and help them out with, because they were not aware. They were one of those practices that think everybody can just do incident to because Medicare accepts it, everybody accepts it. And that is just so not the truth. In fact, I would say, and I know this discussion goes around and around, and I know Terry, if she's still, hanging out with us, I know that's one on the compliance guy. When we watch it, they come around to that a lot, coming back to the incident to issue that causes a lot of problems. That I find now, and I don't know if you find the same thing, Sonal, that more payors don't accept it than do anymore. And that most of them in their and this was when they said, well, it's not in your claims manual. The person at the office said, I read the claims manual and it's not in there. And then again, the payor came back and said, well, it's in this other manual.
Yes.
So it's there.
It's there.
And they say, well, it was available to you, even though there's 200 manuals on the site, and you have to dig through each of them to find where it is. It's out there somewhere. And so they were responsible for it. So they had to pay it all back, that 15% difference, they had to pay it back. But that would be another example of something they would call incorrect coding, on the CERT report when it came out. So, yeah, and just a little side for incident to, lady made a nice little point here. I know that's not what we're talking about today, but incident to equals CMS. That's about where I would leave it with a lot of practices.
Right.
Or definitely have a list and know which payers do and don't take it. It is not something you can just blanket do. You're going to be paying a lot of money back when a payer picks up on that. So yeah, with incident to, just kind of, be very wary, I say.
I say too. I agree. It's a dicey way of doing billing. It's so complex. Like Lady said, it's a Medicare construct. And the people who follow it on the commercial end, they write their own. And you have to be able to dig into their 20 to 30 provider manuals or reimbursement manuals or clinical policy manuals,
Yep.
whatever they title it, you
Yep.
have to be able to find it. You can't just automatically think that they will cover something called Incident 2 because it's not a commercial construct. It's a Medicare construct. Yeah.
And then our fourth one of the categories is the no documentation, my favorite one. So, Sonal, do you have any words on that one?
Yeah, no documentation. Well, what does that mean, right? So, like I said before, if someone on your team doesn't know where all of the documentation is housed and filed away within the EMR, right? And you think you're sending them a complete package of what they want. In fact, you're not. And that might be one of the categories that they, score you in is no documentation, right? Because you didn't actually supply the order, right? Or the proof of delivery if it happens to be a DME POS request that they're asking. So yeah, this no documentation thing is sad. So it looks kind of like, oh, so they just didn't send anything. No, I think it's more refined. You didn't send that order or that proof of delivery or, something like that is what that means for no documentation. Simply not that you forgot to send the entire chart. No.
But it could be.
But it could be
the other thing
you disregarded it.
Yeah. It could be just that you never responded. So, and that's the bigger part on me that I'm just like, come on, y'all, really. They send it, they tell you 45 days, you ignored it. They send you another request, just say, hey, you didn't send this stuff and you still ignore it. Shame on you, really. I mean, even if you internally look at it and say that it's not so good, send it. Don't not send the information. If it's no documentation, it's automatically denied. And the payor is going to end up coming back to you and asking for that money back because you're not supporting it at all. So they're going to want to take it back from you. And that's the thing, too, to remember with these CERT audits, that they say that they're not fraud, they're not coming to look at you specifically. But if they find that you didn't deserve some of the payment you got, the MAC's going to want it back. And if there's some significant things that they look at, like they ask you for 50 charts, 50 records, they look through them and it's just like 80% wrong and it's just, or something egregious, they could then go to CMS and say, hey, you need to look at these guys further, and kind of then they'll take it after that and run with it. So, and ignoring the entire records request is probably one of those things. they're not going to take too kindly to that. And there's going to be some follow-up for that. And you're not going to like what the follow-up is. So just answer them, send something in, send the stuff in. If you look at it and you notice, hey, it's the wrong date of service, or I looked in here and for some reason there's only half a note, or send it with an explanation. I don't know what happened. There's just happened to be, here it is, but don't not give it to them. Not giving it to them is automatically wrong. For those of y'all that are credentialed people, when you take your exams, right? They're all multiple choice. What is something that everybody always tells you when you take the exam? If you don't know, you're running out of time, don't leave anything blank. Right? Just guess at that point. So fill everything out, though. Make sure you answer every question. It's the same kind of concept. Don't not answer this. Don't leave that blank. Go ahead and send what records you have on whatever dates of service they're asking you for, even if there's stuff in there that's not so hot. That doesn't mean because you look at it and go, oh, this isn't good, that you can just ignore it. I found, and I'm sure Sonal, you've been involved in these cases. I had one where they called me up and it was it was on a Friday, and the attorney said that they needed the response by Monday because somebody had put it in a drawer.
Yes.
And because they got it, they were scared when they looked at it. So they kind of hid it away. and it took them until almost it was too late to fess up and show it to somebody. And then, of course, it's all Hades breaking loose and everybody's in a panic. And, you don't want to be, it's already stressful enough when and people use that word audit. Whenever you hear that there's an audit, you're immediately just like, oh, so don't make it worse by compounding it by just leaving it sit. Or, you got the stack of mail and somebody doesn't even open it because they don't realize what it is. I've had places where they throw them in the trash because they didn't realize what it was, because they'll say, this is like the third request. Well, no, they never requested that from me before. And then they ask staff and somebody's like, oh, I didn't know what those were, so I was throwing them out. Then it's like the face palm emoji.
Yeah,
right?
exactly.
So it's really, really important to make sure that everybody knows those things. So lady, out of sight, out of mind. Yeah, they kind of like, well, I'll just put it away for a day or two, build up the courage to give it to somebody. It doesn't mean that you necessarily did anything when you get these requests either, depending on what your thing is in the office. I mean, the onus is on the physician and the APP that did the service to make sure that it was documented correctly, and then of course the coding end of it, depending on, what your position in the practice is, may be involved in that. But, I mean, that's what they're looking at, is the documentation, to see if it's matching what the coding is that was reported for it. But yes, that would be the no documentation. And then they have the final fifth one, which is other, which is just, it doesn't fit in any of those four. So, that usually is like the smaller piece of what they get on the error rates, because most of them will fit in these other categories. And insufficient documentation overwhelmingly is the largest one. Always, it's always like it just doesn't meet up, So let me pull up. Oh, I made a little PowerPoint slide that shows you the figures from 2022 in the category. So I want to pull that up for everybody here. So for 2022, it was 63.6% improper documentation, 13.8% medical necessity wasn't met, 10.5% incorrect coding, 8.3% other, and 3.8% that little no documentation one that, we should never see in there, right? So that's kind of where things are sitting from the overall national kind of standpoint. You can, like I said, if you go to the report, and I put the link in, you can see for your MAC, for your provider type, for, your contractor, all those kind of things, like where their percentages kind of were sitting. So, and like I said, too, after they're finished with the review, they do report, and then they report these publicly, they get published. But then the MAC, after this, because it's not the MAC that's doing the CERT review, it's an independent reviewer. So they do them, they go back to the MAC. Now the MAC also, which I think is interesting, the MAC can appeal the CERT decision, just like you appeal the MAC. So if they think that something wasn't looked at correctly or wasn't looked at according to the MAC's LCD or whatever, that they can go back to the CERT and say, no, this is how it should be, and here's this policy that we have on this, or whatever. So they can appeal these decisions too, which I think is interesting. I like to see some of those conversations, see how does it feel, right? But then after that, once those things are finalized, they do go back to the MACs, and they know who was pulled and whose patient records. And so then they're going to come back to you. And if you were underpaid for something, then you have to be paid. You have to be paid what that difference was, and they have to make it whole for that claim. So if your physician billed 3s and they should have been 4s, they will pay you back that difference, because that's what it should have been. Just like they'll take money back if, you were overpaid. So it works both ways. You get the rub both ways there. But being underpaid because you're underdocumenting or not reporting the services correctly. And a lot of times the underpayments will come because of the misdocumentation, the miscoding, sorry, in E&M services, because that, of course, is the most of what everybody does. So I had a situation where there was a physician that everything was a 3, you know. He was in that because he thought it was right in the middle of the road. It wasn't going to cause any ruffles. And his patient base were patients that all had been with him for like 30, 40 years. I mean, you know, and so a lot of these patients were very complex, multiple comorbid conditions, multiple treatment management plans every time they're coming in. And, you know, and so they're very extensive. And he also didn't feel right, he said, billing them for level 4s. Because, you know, they've been with him for so long, and, you know, I was like, well, okay. But what happened was he got audited because he was an outlier. You know, it doesn't matter being an outlier. You know, if you say, well, I'm just going to undercode these things and that'll keep me safe. It doesn't. You know, the system just pulls you out. If you're an outlier, you're an outlier. So he got pulled, and after they reviewed him, they sent back the review and they told him that he had undercoded, you know, specific ones of what he had said, what the percentage was. They also had to send him a check, you know, with it for the underpayments that he was due from his undercoding. And then they also sent him a letter that said, if you don't stop doing it, we're going to fine you for administrative burden, because we have to keep looking at this stuff because you won't stop it. Just do it correctly.
Right.
So undercoding, overcoding, wrong is wrong. You know, of course, the payers are all over when you overcode it, but, you know, I mean, undercoding still is, they don't like it because then they have to put people in to look at your stuff. So it costs them to then turn around and have to owe you money. So payers really don't like doing that either.
Right.
So you have to watch it from both sides, right?
Agreed. You have to do the right thing. Yeah, I've had providers try that as well. This was years ago. Yeah, try to play it safe, right? And just do all the billing at the same level 3. Yeah, years ago that was, I guess, the mentality. Just keep all my patients at the same service level, even though, you know, so many deserved so much more, right? Because they were very, very sick. But yeah, no, you have to do the right thing and actually code based on the documentation, not just because you think you're going to be playing it safe, and perhaps you won't ever get this type of, you know, request from the CERT. No.
Yeah, and the other thing I was just thinking, it like messes with the bell curve too, the magic bell curve that everybody talks about, right?
Yeah, for sure.
You wonder why everything's at a 3, because if you've got, you know, so many physicians that's all they ever put out there, well, it's going to skew the curve, you know? Yeah, so it's not going to look correct. And don't get hung up on the bell curve thing.
Don't get,
there's a lot of specialties and a lot of practices, because of their patient base, they shift right. You know, and there should peak at 4s, and there's nothing wrong with that. If your documentation supports it, it supports it. That's what it is, you know.
Exactly.
Now, a question that we got, Sonal, if you want to, like, what information should be sent to the CERT contractor?
What information should be sent to the CERT contractor? Well, again, we have to have someone on the team be able to read what the request is asking for, right? And then based on our conversation here today, we have to go behind the scenes as well, right? Make sure, even though your CERT may provide you with a small checklist of things that they're requesting, definitely send all of the information, all of the documentation that supports the medical necessity for that service. We simply can't stress that enough. You have to send all of the documentation that supports that service. So when you look at the PDF report, you know, based on the chiropractic services or based on the DME POS, right? You have to be able to understand what those requirements are, right? Again, based on the LCD for the chiropractic service, based on the LCD for that particular lower leg, whatever brace or knee brace or something, right? All of that has LCDs that require this laundry list, more things that is part of a greater checklist to support the medical necessity for the entire service. So it's really, really important that you review all of those policies to help, support you and defend yourself and your services when these types of certs come in to your office. Then you can really happily be able to send all of that documentation and be able to, get off of their radar successfully, right? That's the goal, to get off of their radar.
And the other thing that I would add in that is not just what you should send, but what you shouldn't send, right? Don't send anything they're not asking you for either.
Right.
Don't like, make sure when you're checking, because I've had people that when they scan and copy, 2 notes will be on there from 2 different dates of service. They're only asking for one of them. Don't give them the other one.
Right. Don't give them the other one. Right.
If they're not asking for something specific, if it's something outside of what is the scope of what they're looking at, don't voluntarily send more than what you need to, which is why it's important, like Sonal said, to have like a point person in the office, that is your, the audit person. If these letters come in and there's any kind of request for records, that it goes right to that person so they can kind of look and determine, one, what is it? Is it just because of a claim that they need the record for to pay it, or is it an audit thing, or is it like a bigger kind of thing? And that person will go through that whole checklist, that Sonal was saying, which I think is a fabulous idea, but if you have one person, then the chances of, oh, I didn't know what it was, and so it went over here, and everybody knows any letter that comes from anybody that says anything about records goes to Tammy, goes to whoever, and then she, of course, cross-trains somebody else for if she's on vacation or if she's not there, that somebody else will know, and that they know that then that's the person to send the stuff to, and let them evaluate it and say, this is what's necessary, this is what's not, this is what we need, and do it by the date,
Exactly.
Very, very important.
Exactly.
Yeah. Because somebody asked if they could ignore a CERT request. That was one of the questions. And,
Oh, no. Yeah. Like we've said, it's not going to go away. Yes. Don't ignore it, or don't think you're safe to just forget about it. Like we said, put it in a handbag and just ignore it, or put it up on the shelf and ignore it. No, we have to deal with it. It cannot be ignored.
Yeah.
No.
So, we are, we're at the top of the hour almost already. So we've gone through an hour again. This was something that I enjoy talking about the CERT stuff too. So I'm really glad that you could come on with me. So people that are attending with us today, I hope y'all have found this helpful. Like I said, go back through the chat, and we put the links in there for you for the CERT report from last year, for the program integrity manual to go and read the specifics on the CERT program, and to that PowerPoint presentation for the CERT program. So you can go and take a look at all of those and make sure, that you're following what you're supposed to be doing. And I am also going to put...
Make sure you look at those appendices in the back of that report. All of those appendices have the top 20, I'll just read it to you. The top 20 for Part B. Number 1 is lab tests. Number 2, office visits established, right? These are huge. Specialists is next. Minor procedures is next. Hospital visits, subsequent and initial. It goes on and on. Psychiatry is on the hit list as well. Chiropractic, obviously, it's always been there. And then eye procedures for cataract extractions. So there are 20. So each of these appendices, it's like A through, I don't know, like Q or something. There's a lot of appendices that you want to dig into, and siphon in and take a look at if your specialty is actually affected. So it's definitely part A, part B, and your DME POS stuff as well. Yeah. That is going to be affected by CERTs. So take a look when you have some time for some fun reading.
Yes. And if you don't, this is the things like we've been saying all along, you farm them out to people that understand it and that you can trust to take a look and either educate your staff on eventually doing it, or taking that part off of their plates, because they can't handle that and everything else that's going on in the practice too. It's most of the practices are running lean and mean these days. Yes. And but you have to address these things, and to let them pile up isn't the right answer. So if you can't handle it or don't have the expertise in house to handle it, contact consultants that you trust. Sonal, myself, Terry Fletcher, Jennifer McNamara, Christine Hall. There's many of us out there that this is the kind of stuff that we do all the time, and would be able to take it off your plate and take it off of your mind from worrying about things like that too. I just want to put up Haley. Thank you, Haley. She said she didn't know much about the certs, and she's already pulled the links up. Great. So that's wonderful. That's why we like doing these things, to kind of bring this kind of stuff to people's attention that may not understand that these are different things and what they mean, and what they can mean to the practice. So wonderful. So again, happy National Doctors Day.
Happy National Doctors Day. Yes.
And have a great Baby Friday, and enjoy your weekend. And thank you, Sonal, for coming on. And
my
don't
pleasure,
forget,
buddy.
I said, we've got the Sonal coming back up. We've got the E&M coming up. So make sure you send your questions, either me or her. You can send them to us on LinkedIn in the little message things. We talk weekly multiple times. So we'll see what we can get to for the next one. So thanks for hanging with us and seeing what is happening in healthcare. And we will see you next time.
See you next time.